Good morning, and thank you very much for inviting me. So one of the things that's very attractive about magnets is they're really fun to play with. But we all wondered whether this guy would have trouble with his heart with that big magnet that close to it. That's one of the things we addressed as we moved along. Okay. Oh, so the first problem that I thought might be amenable to force treatment was pectus excavatum in teenage kids. So we used to do this big operation. I always hated it because I just thought it was too much. But it works. But I thought maybe a better strategy would be if you could just put a little pressure outward on that sunken sternum over a long period of time. It would reform, it would remodel itself. And there's lots of examples of that in biology. So, and the way we thought of doing it without piercing the skin was to put a big magnet on the kid's sternum, and he'd wear another magnet, and over time his chest wall would improve. And in fact, that worked. We've done it in 2 FDA trials, 30 patients, and there's been, the most important thing is we wanted to establish that there wasn't a problem with having a magnet in your body, because the FDA said, wait a minute, it's not just the force, it's the actual magnetic field. And let me just tell you, after 10 years of work on this, it is not the magnetic field. There's no biologic effect, ill biologic effect of the field itself. And to prove that to them, we had to do what Eric showed you. We were trying to convince them that you could have a big magnet right next to the chest for a year, and they said, no, 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 until we showed them the cow magnet. We actually got it and took it back to them and showed them that almost all the cows in the United States have this big magnet next to their heart for a year. So the next thing we thought of that might benefit from a little force outward across the skin, but not piercing the skin, it turns out to be the obstructive sleep apnea. So when you look at this problem as an outsider, which I am, of course, I'm not ENT, you could imagine that if you could just grab somebody's hyoid bone and pull out, it would open their airway when it was collapsed during obstructive sleep apnea. So that's what we propose to do. That is to put a magnet around the hyoid bone, little magnet in a titanium can, of course. and then at night, you just put on this little brace on the outside with the second magnet in it. It pulls the magnet forward, it pulls the hyoid forward, and it opens your airway. Pretty crazy. But it works. So here's cross-table lateral. The white stuff is in the back is the airway, and that's just showing that when you apply the outside magnet and it pulls the inside magnet, it pulls the hyoid and opens the airway. We're in our first, thank you, FDA excuse me, trial, and we just did our 3rd patient, and they are doing very well. That's the first patient. When it came to a year when he was supposed to be explanted under the FDA trial rules, he was so deliriously happy with the thing that he refused to have it explanted. So there's nothing the FDA could do about it. And his apnea-hypopnea index, which is just an objective way to measure your obstructive sleep apnea, went from horrendous, above 40, to normal. So the final thing I wanted to talk to you about is the idea of compression, magnetic compression and anastomosis. And I know there's been a lot of work done on this, certainly by Michel Gagné, and I think it's very promising. I'll show you our work on it. Of course, the idea is to have an alternative to the way we've done things all our lives, which is suturing and using the wonderful stapling devices. So we've been working on this for a long time. And I wanted to just show you that amazingly, once we crafted the magnetic device itself, this very simple 2 rings inside polycarbonate with the rare earth magnets. And then we crafted the geometry of the mating surfaces. That's the key, the geometry of the mating surfaces. We could get perfect anastomosis essentially every time. So we've done over 100 anastomoses in pigs, now about 15 in monkeys, and we've never had a leak or a complication. It's astounding. Nothing in my career has ever worked 100% of the time. The reason it works has to do with this engineering. Excuse me. This is a pressure map of the pressure exerted by the 2 magnets on each other. And the far end is the hole in the magnet. And then you see there's red stuff, which is very high pressure on the inner lip of the magnet, and it drops off to very little pressure on the outside of the magnet, which gives you the graded pressure and a good anastomosis. It makes beautiful anastomoses. The device, of course, falls into the lumen and gets pooped out. It's as strong or stronger than stapled or sutured anastomoses in our pig studies, and there are the 2 magnets inside in an open operation. Oh, that's the first human. So very recently, we got permission from the FDA to do the first human cases. And this is, I think, the first one. So you first see in the first X-ray, the mated magnets are in the right lower quadrant. It's an ileal anastomosis. And then a few days later, they're in the colon getting ready to come out. And let's see, we've done 5 of those cases and 3 others, and all of them have worked perfectly so far. Here's a fun thing you can do with magnets. You could do this without an operation. You could essentially defunction an ostomy. We've done this a couple times in kids in Argentina, and again, it's worked perfectly. But you can put those 2 magnets in, let them make their anastomosis, and it defunctions it. Then you can find out whether you can close the ostomy. Sort of a fun strategy. Okay, and the final case is going to be presented here later by Carter Laberries. Was just an amazingly awful case of a guy who couldn't tolerate an operation for his small bowel obstruction, but he had an ostomy from a previous perforation and big mess. And so we were able, just laparoscopically and using interventional radiology techniques, to work one magnet past the obstruction into the big dilated piece, put the other one on the outside, and have them snap together, make a new anastomosis across the obstruction without any operation except that endoscopic placement. And he woke up and went home. It's just amazing. So here's the picture of how we did that. This is Carter Laberries. That's the anastomosis after a week or so. So the final thing I'll talk about is also, I think, something you're familiar with. The idea that you could somehow capture the good effect, good metabolic effect of bariatric surgery with a littler operation. So as you know, bariatric surgery cures diabetes like that, but not directly related to weight loss. Why is that? Lots of interesting, fun theories. We sort of bet on the hindgut hypothesis. That is, I thought that if you could just take a little juice from your upper GI tract, chyle, biliary, and touch it to your ileal mucosa, you would get an endocrine effect, that is GLP-1 and those things, that would essentially, that causes the good metabolic effect. And so we studied that, and we think that this is the mechanism. And from that, we hypothesized that an operation that would be useful in a human would be essentially a jejunal ileal bypass, or even a duodenal ileal bypass. And we thought we'd study it in pigs and monkeys. And here's some work from the monkey experience. I just want to quickly show you that when you do it, this is not definitive. We didn't have enough numbers to make this definitive, so no claims. But every parameter moved in the right direction. Every parameter moved in the right direction with this simple side-to-side bypass. GLP went up, triglycerides, they all went in the right direction. So right now, we're doing a more definitive study with 10 monkeys. We did the first 2 a couple weeks ago, and with a very complete metabolic workup before and after. And so we should be able to answer this question, and it's at least interesting. Those are our conclusions so far. Thank you for your attention.